record. All right, so we had basically readings from almost all of our, I think actually all of our materials this week. So first is the van der Kolk, talking a little bit more about some of the neurobiology, touching a little bit on what we talked about a couple of weeks ago as well, or a few weeks ago, as well as the concept of attunement. So what we're really focusing on this week is the effects of complex trauma in childhood. So whether that's infancy, early childhood, adolescence. So you have an idea of how to work with that when you have not only maybe an adolescent in front of you, but also when you have an adult in front of you. So a lot of this is really focused on encouraging you to take on a trauma-informed approach, as well as assessing for history. And a lot of the information that you'll be learning today will inform some of your assessment. All right, so attachment and attunement. So one of the notes, again, as you know, I just want to highlight some of the pieces that we are learning about. So if you have any questions, comments, feedback for me, please don't hesitate to speak up. So if you think about a young child and how dependent that child is on their caregivers for literally everything, that if you are in an environment or with caregivers, with attachment figures who don't attend to your needs. So, you know, children have basically one mode of communicating. They cry when they are hungry, when they are tired, when they have, when they need a diaper change. So all of those like limbic system needs are vocalized through crying, and the hope is that you have an attuned caregiver that comes to you and attends to you. We also learned about the concept of mirroring, of, you know, as a child, as a baby, you know, we mirror our caregivers, or those, our caregivers, and they mirror us. So in terms of facial movements and stuff like that, laughing. So that's one of the ways that we learn about ourselves, is through the mirroring of our caregivers. So for children who are abused and or neglected, so remember, abuse and neglect, they're not separate things. They're kind of on a continuum, where one is more like active and one is more kind of detached, but they are both conceptually under the umbrella of abuse. So if a child is abused or neglected, we'll talk more specifically about abuse here, then the whole world, so their concept of the world is that it is largely unsafe. So everything potentially that a child comes in contact with is a trigger. So if you are accustomed to poor outcomes, harmful outcomes, abusive outcomes, you will assume that that is going to happen. So one of the things that van der Kolk talked about in the book was about, like, not only Rorschach test, but the thematic analysis test. So the TAT, or thematic analysis test, is where there's these like pretty benign pictures. So he talked about how there was, like, for example, an adult man like under a car, and there were two children kind of watching him under the car. And for children who were not abused, this was a very benign picture. So there was usually like pretty, quote, like predictable, like, again, benign outcomes of like, oh, that's a dad under the car, like fixing something, and these kids are playing. And then the children who have been abused, there were very clearly like pretty morbid, disastrous outcomes, where, you know, the car is going to fall on the dad and he's going to get cut in half and blood's going to squirt everywhere. So that gives you an insight to the like default mode of children who have been abused, where the assumption is, and the adaptation for them is that, you know, bad things are going to happen. So just being aware here that everything is a trigger. So, a stranger walking into a room, the assumption could be this person is here to hurt me. An image that could be reminiscent of abuse, or again, just a benign image could be seen as very malignant. So being aware that if the world is filled with triggers, that's going to present in a specific way with the children. So the concept of a secure base. So we know from Bowlby's work that there's secure attachment, a secure base, insecure attachment, and insecure base. Secure is under one umbrella, and then insecure, as we know, is disorganized. You guys can help me out here. I always forget that there's like disorganized, anxious. What's the last one?
Anxious avoidant.
Avoidant. Thank you so much. Yes. So that can kind of manifest in those three ways. So we are social creatures and we need others to survive and thrive. So as we grow up, we learn how to take care of ourselves, but that's informed by how our caregivers provided care to us. So these mastering the skill, for example, of self-regulation, which would be one of the kind of presenting concerns when you're working with not only an adult, but an adolescent, is informed by our caregivers. So again, our ability to self-regulate, we do that, we learn about it from modeling, but we also learn about it from having our caregivers be attuned to us. There's this harmony in the way that we give a signal as a child and a caregiver attends to that. So if you have children, when children are reliable sources, they have this advantage of, again, having a more benign view of the world. And there's also a seeming buffer where the default isn't survival, it's not adaptation, where developmental milestones are able to be met because the energy isn't being put into adaptation or survival. It's just able to kind of explore and express. So just knowing that the ability to explore and express, self-exploration, self-expression, it really is a privilege that not every child is afforded. And there are potentially lifelong residual effects of that. So having a safe haven, having a secure base allows for the child to work on self-reliance and then have this sense of sympathy and helpfulness, the ability to help others when they're in distress. So again, the concept of and the exposure to a secure base has these lifelong reverberations with the child. And then again, attunement. So we learning how to manage arousal. So emotions are inevitable, but the expression, the acknowledgement of, the knowledge of emotions, as we know, as we're working with our own clients and having our own lived experience, family and friends, that it varies quite a bit. So attunement is, as I mentioned before, when a child signals distress, discomfort, whatever, that the caregiver attends to that. Also, when the child is, squealing with joy or having a good time, that the caregiver engages in that as well. So there's this predictability and like symbiotic nature. There's this, again, mirroring that happens between the child and the caregiver. So through this experience of attunement, we learn how to manage arousal because, so for example, when we're in distress, say we're hungry and our caregiver predictably attends to us, we know that distress is temporary. Like we know that we will have someone to help us with that. And then as we become more self-reliant, because we have this secure base, we can learn that these emotions are temporary, so I can like move through this. I know this isn't going to last forever. So when there's misattunement, that reassurance isn't there. So it becomes incredibly distressing. I don't know when this is going to end. And I have never been attended to, and if no one's shown it to me, how am I possibly going to learn how to do that for myself? So it's kind of this like amping up of the experience. So these intense sensations, so for example, safety, comfort, mastery is a foundation of self-regulation. With securely attached kids, they learn the difference between situations that they can control and situations where they need help. So with misattunement, there is really no control ever. Or the thought is, this is something that I can control when it's not mine to control, but largely the message is I have no control over anything. I'm doing my part. I'm sending signals of distress. I don't know what to do with this. But after a while, the child just kind of learns to potentially like give up on the distress, or just assume that like nothing's going to happen to help them. So children with histories of abuse or neglect learn that their terror, pleading, and crying don't register with their caregiver. So nothing they can do or say stops the abuse or brings attention for help. In effect, they're being conditioned to give up when they face challenges later in life. So this manifests in a lot of resignation with adult clients, for example, where they really have no idea what they can control. The assumption is like, I'm flawed, I'm a failure. So again, for those of you who are taking the CPT training, one of the concepts in there, and for those of you who are not, I'll tell you this right now, because this isn't really talked about so much in TFCBT, is this, what is the term? The myth of a fair world, or the myth of a just world, where if everything is fair, if everything is just, so the kind of tagline for this is good things happen to good people, bad things happen to bad people. So we're for whatever reason, this message is like really internalized in us. Parents are doing their best, but they're not really helping us with sending this message. So anyway, if the message is bad things happen to bad people, and I am experiencing abuse, then I must be bad. Because if the world is just, then your brain is going to do what it can to make sense of what's going on. So it's either I'm flawed, or this messaging, this internalized message of the world is just, the world is safe, the world is good, that's got to go out the window. So it's kind of, there's this dichotomy of I must be flawed, or the world must be random, unsafe, no one is to be trusted. So there's this like kind of accommodation, or this assimilation that happens when a child is in an abusive environment. And again, that carries into adulthood, as those of you who are doing the CPT training know, like these are adults coming to treatment because they still believe this just world myth. So becoming real, like realizing that you are a human being, and that my signals, my expressions, they matter, they're valued, they're acknowledged. So, and unfortunately, there still is some mother blaming in this. Also, we do know that mothers tend to be the primary caregivers. They have, capabilities in terms of feeding and that kind of stuff that fathers, or like the non-birth parent just doesn't have so much. So there is quite a bit of burden. There is quite a bit of responsibility that falls on moms. So if you have any thoughts or anything on that, I do want to give some space to that. But yeah, so kind of staying with the very historical kind of like mother burden in terms of children and stuff like that. So again, when a child has very few skills in terms of signaling to a caregiver, I need something. So the caregiver has a ton of power and a ton of control. Child is incredibly dependent, as we know. Even children who are fed, clothed, changed, but don't have any physical contact, they die. So like, we need that attunement as children. So if a mother or caregiver can't meet their child's impulses and needs, that child learns to accommodate the mom. So if I'm, or the caregiver, so if I'm not being listened to in this, I'm going to figure out how I can get like the most attention or to get my needs, or I'm going to change my perception of what my needs are. So when you're discounting these inner sensations and you're trying to adjust to what the caregiver needs, you perceive yourself potentially as something being wrong, or that I'm not allowed to just be me. I must play a role. I must do something to provide for a caregiver, when at that point in development, it's really not bi-directional in that. Like, the child's not supposed to provide the caregiver anything. It's really a one-way, so developmentally, it's a one-way street in terms of the adult providing something to the child. The child's really not expected to, or shouldn't be expected to, provide anything for the caregiver. So when that flips, that changes the child's ability to be. Then they have to perform, they have to provide. So there's this kind of like almost this conditionality to their realness. So attachment, again, I'll touch on this. So we nailed them all when we were talking about the insecure attachment. So attachments, think there are 3 types of organized attachment strategies. So again, these are adapted to the caregiver. And again, the caregiver, their attachment is informed by their family of origin. So it really is, it goes back generations of how were you attended to? Are you going to do something different? Are you going to do something the same? Because as we know from a multi-generational perspective, people tend to take like kind of 2 paths with how they were raised. They either say, I'm going to do the same thing, whether it was, healthy, unhealthy, or I acknowledge that this wasn't ideal and I want to kind of break this cycle and provide my children something different. So, people in context, it doesn't mean that the former is bad or anything like that. It really depends on, exposure to other ways. Again, attachment, connection to authority, worldview. There's so many trauma, there's so many aspects that inform how a person raises their own children. So we have secure, avoidant, and anxious. We also have disorganized. So secure, avoidant, and anxious fall into the organized category. Naturally, disorganized has its own category. So like I said, these attachment styles are adapted to elicit the best care that a particular caregiver is able to provide. So infants who encounter a consistent pattern of care, even if it's marked by emotional distance or insensitivity, they can adapt to maintain the relationship. So the avoidant attachment, as this child grows, this is dealing with whatever emotions or whatever's going on, but not feeling them. So they're not really attending to them. So these might be they look detached. They look like they really don't care. And this is due to generally having their needs not attended to at all. So I'm going to suppress this distress or this hurt or whatever is going on, and I'm just going to go through this. And then anxious or ambivalent is you're feeling, but you're not dealing. So it's just this kind of like anxious undertone, where again, this can look as, clingy, but not really being soothed. So like, for example, when a caregiver might, they use a lot of attachment theories use the example of like being at a playground, where when their caregiver leaves with an anxious attachment, they're, distressed, but they're not soothed when the caregiver comes back. So the marker of a secure attachment is the ability to explore. So you have your secure base. Your parent, your caregiver is this secure emotional base for you. You're able to go off and explore. And then when they're not there, you're like, oh man, where are they? And they come back and it's like, all right, I'm gonna check in with you. All right, we're good. Okay, now I can go explore again. So with avoidant and anxious, there's a distress. Well, mostly with the anxious, there's a distress when the caregiver's not there, but the inability to soothe when the caregiver comes. Avoidant is there may be some showing of distress, but it's really that the child's kind of unaffected by the caregiver when they leave. And then disorganized is just similar, but it's almost a combination of the two that we're talking about here, is that there's, again, this undertone of just dysregulation and fright, and there's really no solution to it. So it's a kind of this constant state of arousal where there's not the caregiver can't really soothe their child. So we'll talk about kind of how that may inform an abuse cycle, but they would be considered like the difficult child by like, the parent goes to like parenting or is talking with other parents. It's like, oh, I can't soothe my child. That might be an indication of some level of disorganized attachment. It also can be colic. It can be other things. But again, putting some of the onus on the parents, that can be it's a learned behavior based on the care and the attunement that is provided to the child. So
Dr. LaPon?
Yeah.
That makes me think of, does that kind of fall in line with tantrums? Like tantrums when child's still?
Not necessarily, because tantrums are developmentally normative. It's a dysregulation, but again, the how the parent attends to that can inform some adaptation of the child. So tantrums are by no means like an indicator of trauma or an indicator of lack of attunement or anything like that. So what you could assess, for example, is how the parent attends to the child. So if the tantrum is met with, for example, a always fixing, like providing options, and like if the parent becomes dysregulated and is very, they're modeling to the child this dysregulation based on dysregulation, that child may learn, okay, my parent can't handle this, so there can be an adaptation to attend to the needs of the caregiver. If the tantrum is met with shut up, get over it, then the child can learn, oh, it doesn't really matter how I signal to my caregiver, they're just not going to do anything anyway. So there's no learning of how to regulate that. Of course, there's no like perfect formula. Parents are inherently human, they're flawed, they're doing their best, they're, situationally distracted and all of this type of stuff. So the data show that I think it's about 65% of children are securely attached. So it's like not great, but it is the majority. So tantrums it's a signal that the child is in need, is in distress. Can it be learned that this is the only way that I get attention? Of course. So a lot of the onus really does fall back on the parent. So am I answering your question, Danny?
Yeah, definitely. Because I just experienced a few of those, and I was trying to just, trying to see where they fit. And yeah, no, definitely. Thank you so much. Yeah.
Yeah. So it really, so just, some parenting stuff here is like one of it's difficult to do all the time, right? Parenting is a super difficult job. But it's the validation, it's the being seen. Oh, you're having a difficult time. Is there something that I can provide you? Is there maybe something, can we do some deep breathing? Can we do some self-soothing? So it's really like validating that the child is uncomfortable or in distress in some way, not necessarily doing all the work to take it away, but not also going, you're fine, shut up. So there's this middle ground of, I see you. What do you need? I can't do this for you all the time. And then show, like, teaching some skills around that. So it's saying, okay, my feelings are valid. My caregiver attends to them. And then I'm learning to gain some control of that because my caregiver is showing some confidence in me and in my ability to do that. So again, it's not the perfect formula. It doesn't work for every kid. Parenting is largely, parenting experts are, we're doing the best that we can. But really it's usually about like, what's the word I'm looking for? Like self-marketing or something, like there's a lot of parenting experts that have no credentials, but then the question is like, what are the credentials for this?
Yeah, and a child's tantrum it really is dysregulating, like, I mean, all of my education and knowledge and training went out the window when I was trying to deal with this 5-year-old's tantrum.
Yeah.
I was trying to talk to her, trying to convince her that her perceptions weren't, were, and she was just like, I hate you, like, get out of here. Yeah.
Yeah, you learn that the reasoning with a 5-year-old, it's fruitless. The abstract concrete thinking there, it doesn't allow for you to really challenge cognitions or perception or anything like that. Yeah, you're learning about all the developmental aspects of working with people at different stages in their life. Great question, Danny. All right, so becoming disorganized within. So again, if you are not attended to, if you are not validated, if you are not acknowledged, then you find it can affect you in a way where you learn, my needs aren't important, I am inherently flawed. So again, your brain is trying to make sense of why your needs aren't being met. So here, the reactions of children to painful events are largely also determined by how calm or stressed their parents are. So I go back to, remember in our first reading with van der Kolk, how there was, I think the child was like maybe 8, where I think it maybe was anyway, the child, pronouns doesn't really matter right now, drew the Twin Towers smoking, and then drew a trampoline at the bottom. So that signaled some like, modeling by the parent that was helpful in the child being not so traumatized, being very close to this act of terrorism. That was very dysregulating and horrible for lots of families who lost loved ones, lost all kinds of things. So caregivers are really crucial in a child's ability to be calm and self-soothe through modeling. So if you as a child have no internal sense of security, you can't really distinguish between safety and danger, because these are concepts that you have to experience one to kind of know the opposite. But if you, or quite frankly, experience one and the other, but so if you're experiencing danger, that's when you are helped. That's when you are attended to. That's when you get some attention or connection from a caregiver. But if you always are like dismissed or feeling as though you're not safe, you're not really going to understand how to distinguish between the two. So if you experience safety and you're attended to in danger, you know that these two are fundamentally different experiences. If you are in danger but not attended to in that, you don't really know what safety is. So in order to help this, so again, we're evolved creatures, we have brains that try to protect us. So if I am consistently distressed, my body is going to go, holy moly, there's like a lot of cortisol that's happening here. You know, our blood pressure is high, our heart rate is high, we are elevated. We've got to engage some systems here to like chill out. So then your brain can dissociate, can numb out. So if you're feeling this, if you're numbing out, you can kind of feel, for lack of a better term, dead. So if you are feeling a sense of aliveness, then you may do dangerous stuff just to get a sense of any feeling at all. So we'll talk a little bit more about this when we get to adolescence and some of their, you know, like self-regulating behaviors that are considered risky, and why they may be doing this. So again, if you conclude from this abuse, neglect, that you're a terrible person, because like, why would a caregiver, somebody who may like claim to or is supposed to love you, why would they treat you like this? Then you're going to expect this to happen from anybody. So if my parents treat me this way, why would anybody else treat me differently than this? And then the message is probably that you deserve it and there's nothing you can do about it. So this complete lack of control, again, this is how you would experience adults coming to you feeling this incredible sense of resignation in life, of like, I am depressed because I can't do anything, and I can't do anything because I'm depressed. So this, you know, very difficult cycle of depression or resignation and how it affects somebody. So long-term effects, so going more into adulthood. So when mothers and their infants were studied, they were observed with this disorganized attachment style that they were noticing, it looked as though the caregivers weren't doing this on purpose. They just really didn't know how to be attuned. So one of the examples was, I think it was like a mother with her infant that was like in the infant's face and coming out in the infant's face. And then the child was like kind of turning away. So indicating to the mom, I've had enough, I need some space. And the mom like really being like, wait a minute, what the heck? And then kind of like turning the baby's face to them. And then the baby became dysregulated. Like I was trying to tell you to give me some space here, but there was this misattunement that was corrected quickly of like, oh my gosh. But then there was still this reaction from the mom, which again, it's these micro interactions aren't going to be like, oh, that was, you know, now that child's going to be misattuned or have this attachment style. It's the consistency of that misattunement. So some of the hostile or intrusive mothers were more likely to have childhood histories where they had physical abuse. So again, it's always humans in context. So they or physical abuse, or they witness some kind of domestic violence. And then the more withdrawn kind of dependent moms were more likely to have histories of sexual abuse or parental loss. So this is just helpful potentially to understand. And I think it can be easy as a clinician, right? We're humans in that room. It can be easy to see like this child that's experiencing dysregulation and really looking at the parent of like, you know, like you shouldn't have even had kids. Like, look what you're doing to this kid. I think seeing the parents in context, it can be helpful to have some more compassion. So again, if they're coming to you, there, you know, may be a history of abuse. It really is still up to us to see people as human and to treat them with compassion, even when they've done really terrible things. So if they're coming to you, that means that they're wanting to change, or at least they're thinking about it, toying with it a little bit. They may not be in the action stage of the trans theoretical model. They may be in the contemplation stage, but it's not going to help you, or it's not going to help the person to be shamed about what they've done. And, you know, there's of course all the issues of reporting and stuff like that, but it's a little beyond the scope of what we're talking about today. So one of the things with disorganized attachments is as children become more and more inconsolable, if they're sullen, if they're resistant to their misattuned moms, the moms or the parents, again, they happen to say moms due to the study that they were conducting, that they were talking about in this book, that the caregiver became more frustrated, defeated, helpless. So then when the caregiver kind of sees the child not as a partner that's attuned to them, or in this attuned relationship, it can become so frustrating and raging, and this feeling as though there's this, disconnected stranger, that can set the stage for some abuse, or that can set the stage for some neglect. So just being aware of how that interactional pattern that happens. Yes, the onus is on the parent. They're getting feedback from the child that is dysregulating the parent. So with this long-term misattunement, and again, with disorganized, it is, even if my caregiver is here, I'm still dysregulated, the parent can feel incredibly defeated in that and feel like there's nothing they can do, and almost as if the child's like this adversary. So emotionally withdrawn parents had the most profound and long-lasting impact. This emotional distance and role reversal, in which the moms expected the children to look after them. So again, it's not inherently it's a bidirectional relationship because of attunement and mirroring and stuff like that. But the child is not shouldn't be expected to provide the parent with any care. It is a unidirectional relationship in that way. So this emotional distance and role reversal were linked to aggressive behavior, not only against themselves, but others when they became young adults. So that's the long-term effect of this emotionally withdrawn and role reversal experience as an infant, and how that affects the children or the humans, like the infants, as they age. Okay, so dissociation, knowing and not knowing. So there's a lot of importance to receiving a sympathetic response. It helps both infants and adults, right? Like when we're distressed and someone's like, oh my gosh, I see you. How can I help you? That's like, oh, cool. Like I'm seen, I'm validated, I'm acknowledged, I'm valuable. It can help against extreme levels of frightened arousal. Again, if your caregiver consistently, that's the piece here, consistently ignores your needs, or it potentially sends a message that they resent your very existence. We know of terrible messages that caregivers have given to children. I never should have had you. I should have had an abortion. I wish you were never born. Just these terrible things that are very easily internalized by a child. Then you just learn to anticipate this and expect it and believe you deserve it. So what these children do, again, to adapt, they still need to survive. They're working with the caregiver that they have. So you can try to block out your caregiver's hostility and act as if it doesn't matter. But your body is likely to remain in a state of high alert. So you are conditioning yourself to say this doesn't matter, and then your body is still being activated by this. So one of the most devastating long-term effects of this shutdown is not feeling real inside. So when you don't feel real, nothing matters, and it can make it impossible to protect yourself against danger. So we'll talk again about how this manifests in adolescence, older adulthood in terms of interpersonal relationships and self-harm and stuff like that. So this lack of safety in the early caregiving relationship can lead to an impaired sense of inner reality, being potentially excessively clingy, which sometimes I have like a difficult time with labels like that, but it's in the reading. And so for me, like clingy is, it can be pathologized, or it's like potentially just like normal connection seeking behavior. And depending upon the recipient, it can be labeled as something negative. So I encourage all of you. So as many of you know, and I think I've mentioned in class before, I'm like a narrative therapist. So language is very important. And it matters. So talking about like clinginess, it can pathologize something that is like a pretty normal need. So I say this to encourage you to be very aware of the language that you're using, and trying to be as neutral around the language that you use, because even if it's, because I just think of like kind of colloquialisms or things that are in like our normal rhetoric that can be really like dehumanizing or pathologizing of something that really maybe it's like based in the patriarchy, based in white supremacy, based in some other oppressive system. So I know I'm going on a tangent here, but my message to you is to be really aware of the language that you're using. So a little activated here by the term clingy. So it can also result in some self-damaging behavior. So things like poverty, single parenthood, maternal psychiatric systems, they did not predict any of these symptoms. So this goes back to, some of my researcher identity. And one of the things that I think we really do a disservice to our participants in research, and ultimately that like informs our clinical practice, is that we look at these like demographics that are risk factors. So I've mentioned it before, it is always worth a mention. I'll say it for every single class as long as I'm a professor, is that like being a woman isn't a risk factor. Sexism is a risk factor. Being a racial minority isn't a risk factor. White supremacy is a risk factor. Just for example, so instead of putting the onus on the person, you really want to identify the systems that negatively impact the person. So it's really easy. So it's like, poverty isn't necessarily a risk factor. It can be capitalism or like the exploitative strategies of corporations or something like that. So I just really want us to think in terms of systems that affect the individual. So with dissociation, so when you're working with an individual who has experienced complex PTSD due to misattunement, abuse, neglect from a caregiver, you need to address not only the imprints of the specific traumatic event, so the index event, that's usually what the terminology is working with this, but also the consequences of not having been mirrored, being attuned to, or given consistent and care and affection. So giving space to talk about that, and also educating an individual. So again, if the message is, I am inherently flawed, something has to be wrong with me for the type of care that I have been given, you've got to help that person unlearn that narrative. So then some of the consequences of this misattunement, this not being mirrored, not giving consistent care and affection, it can result in or contribute to dissociation and loss of self-regulation. So again, caregivers are incredibly important. Parenting is a very important job. So one of the things that we do and we provide in treatment is restoring this sense of synchrony. So our relationship maps are implicit, they are etched into our emotional brain, and they're not reversible simply by understanding how they were created. So essentially what this is saying is insight is not enough to say you weren't mirrored, you had a misattuned caregiver, you weren't consistently cared for. It's like, cool. Now what do I do with that? So that realization, so it's, I'm not saying it's not important, I'm saying it's not enough just to say, oh, it was misattunement. Great. So starting there, that's a starting point, can help the person start to explore ways to connect in their relationships now. So potentially for their own sake, and also to not pass this attachment on, this attachment style onto their own children. So there can be some almost like vicarious healing through seeing your children thrive. I think I've used this example in class before, but I had one of the best mentors in my doctoral program. And so he grew up in a very abusive household. Again, my apologies, but I think it's, if I've shared this before, but I think it's very poignant here, is like this benefit of seeing another person that you had some influence on experience something like better, healthier than you did. So he grew up in a family in Mexico, which is relevant, with a very abusive, both physically and verbally abusive father, and kind of a like more like complacent mom. So mom didn't really intervene in any of the abuse. She was also a recipient of it as well. So his research focused around immigrants from Mexico who working with parents who were at risk of, so they kind of indicated they were either screened or indicated, you know, this frustration with their children where they were at risk of abusing or neglecting their own children. So he ran this intervention group, teaching them about like a parenting approach that helps them be attuned to, care for, and feel confident in their ability to care for their kids. And so time and time again, he would get parents that said, thank you so much. You know, this intervention and this program was so meaningful to me. I've learned so much. I have a completely different experience and relationship with my kids. And that was helpful for him. Also, I think contextually, one of the important things is that like his dad had passed away. So there really wasn't any ability to kind of like share with his dad how he had been maybe negatively affected by his caregiving. So I say all of that because it can be incredibly powerful to be the person that stops this cycle. And it can be inherently healing for the individual to know that they played a part in the benefit or like better living of another human being. So please don't overlook the power in being kind of almost like an agent of change, a point of change in a generational trajectory as well. So in terms of synchrony and feeling a part of something, one of the things that you can also do with your clients is encourage them to take part in some social activities that can foster a sense of attunement and communal pleasure. So again, this attunement of, you know, a shared goal, of a mirroring, of a shared sense of purpose with these group activities. All right, well, I think that's a good stopping point. We got through the first reading here. I'll move a little bit quicker moving forward to give us time for that drawing. But let's go ahead and take a 10-minute break. I will see you all back here at 11:07. All right, everyone, let's go ahead and come back. So any questions, comments, concerns on anything I've covered so far? Anything in the reading that came up for you? So this was in the van der Kolk reading that was unclear that you may want to talk over with the group? Okie dokie, everything's clear. All right, we can keep rocking here. So moving on to the cortoi text. All right. So complex trauma in childhood. So as you've learned in this class, the readings do overlap, but there's like the nuances of information that each of the readings cover in a different way. So one of the concepts was the types of trauma that children can experience. So there's type 1 trauma, that's a single incident. It can be a one-time or short-term event that seems to come out of the blue, maybe something like an earthquake or a natural disaster, or it can even be at the hands of like interpersonal violence, but it just happens once. So there's the list on the left-hand side of the different traumas or experiences that can happen and what this type 1 trauma could look like. Then there's type 2 trauma, which is what informs a complex, our concept of complex PTSD. So I'll talk about this a little bit later, but it is not in the DSM. But it's a way to conceptualize, and I'll also kind of give you a quote, like workaround of a way to utilize a very similar diagnosis to help inform care. So this is repetitive or complex trauma, and I'll define complex trauma for you as well. I think it's really important to understand what exactly we're talking about when we say complex trauma, particularly because it's not a DSM diagnosis. So this refers to ongoing physical, sexual, or emotional abuse or neglect and other forms of maltreatment in the nuclear family or extended family. They also said quasi-family. I'm not really sure exactly what that means. Does anyone have like a thought on what a quasi family might be? You can take a stab at it, anyone.
I'm just thinking maybe it's someone you consider family, but it's not blood relation. Like someone that you call an aunt or an uncle, but they're not really related to you.
Yeah, and maybe this is my maybe it's a bias coming out. Maybe it's a self of the therapist thing coming out, because I think, the definition of family is evolving. And thank you, Miles. So to your point, it's largely defined as like blood related. But when we think of close kind of kinship, and I know kinship has an inherent kind of like blood relation in the definition, doesn't have to be blood. So anyway, just another thing to think of is your conceptualization of what family is and who constitutes family members. So it was largely thought that type 1 trauma was much more prevalent and common than type 2 trauma. And what we're finding is that type 2 trauma is much more common and prevalent than we thought. So again, thinking back to the history of trauma and how, when Freud was doing his research and being like, oh my gosh, like I'm finding out all of these stories. Dang, that means that like a lot of people, like if this is true, it means that a lot of people are being mistreated. Nah, I'm just gonna I'm gonna disregard this because like I can't handle this. So its reality and its credence has been dismissed in the past. So, and that permeates the larger societal narrative, right? So just know, unfortunately, that type 2 trauma is a lot more prevalent and common, I think, than what we could say is like previously recognized or that we'd like to think. So some of the effects, I've covered this, but again, just some of the nuances and different language that are covered in the different texts. So self-integrity is profoundly shaken. We know this. Also, if you downloaded the PowerPoint or using the PowerPoint in Canvas, I spelled effects wrong in the first one, so I changed it. So I'll probably upload this one. So the child incorporates, again, these lessons of abuse. So of course, these are in quotes, into a view of themselves as being bad, inadequate, disgusting, contaminated, deserving of mistreatment and neglect. So this takes me to one of the case studies or the examples that was used in one of the texts. Actually, I think it might have been this text, where a therapist was working with an adult survivor of childhood abuse. And by virtue, and I'll talk more in detail about this in a few slides, when they expressed compassion and patience and grace with the client became dysregulated. They were disgusted by the niceness of the therapist. And this is where we'll talk about disparity and like consistency with, you know, counter conditioning and stuff like that. But it's I like this very internalized message of I don't deserve this, so I'm disgusting, so I am disgusted when someone treats me this way. I don't know what to do with it, so I'm going to you know, have it fit my existing narrative, because this is abnormal. How this therapist is treating me is abnormal. So just telling you that, you know, it may be something where you're kind of taken aback of like, well, I'm showing you compassion and patience and I'm attuned to you and all of these things, that the response may feel like illogical or random or disproportionate. But remember, this is a person that needs to unlearn years and years of really negative messages and a very negative internalized schema, view, belief system of themselves. So these misattributions and related schema about their self and others are most common, and they're the most common and robust assumptive consequences of chronic child abuse. So feeling bad, inadequate, disgusted, contaminated, deserving of mistreatment. These are some of the most common assumptive consequences. And they can be essentially debilitating in terms of not only healthy development, but the healthy development of relationships. So if you believe that you are inherently flawed to the deepest level, you're not going to develop a sense of integrity, sufficient, you know, self-efficacy, self-esteem, and then that's absolutely going to permeate your ability and feeling of deserving of meaningful, connected relationships. So trauma in latency and adolescence. So I wanted to highlight this of these. So these are coined, usually risky behaviors, self-harming behaviors. And I really liked the kind of reframe on this. And again, it's the depathologizing. That's a lot of what trauma-informed care does, is depathologizes and puts into context why a person would be acting in the way that they do, responding in the way that they do, believing in the way that they do. So I really liked the term tension reduction behavior. So again, if you are feeling terrible about yourself, believing that you are undeserving of love, care, affection, connection, feeling so isolated, so different, particularly at adolescence. So the fear of difference, you know, there's a true kind of like kind of herd mentality in adolescence, that I don't want to stand out. I want to be like everyone else. So you got to suppress this stuff in a way, right? You got to cope with these things. You got to adapt to this feeling. So this can look like, or what can manifest in our behavior, such as substance use, disordered eating in terms of binging and purging, self-mutilation, suicide attempts, impulsive, like maybe high-risk behaviors, like where you are, you know, jumping off of a bridge into a river, or trying to outrun a train, things like where you'd go, what the hell are you doing? Indiscriminate sexual behavior, where again, if it hasn't been reinforced or taught to you that your physical boundary is to be honored, you don't know where your body ends and where another person begins. So that physical boundary, if that is violated, the internalized messaging can be, you know, the purpose of my body is to be used for another person's pleasure. It can also be that it's a quick way to feel connected. So it's not always, of course, like none of these are like broad brushstroke, like definitely trauma, like there's definitely been trauma. What I am wanting to impart in you is that if you're seeing this, to have it at least in the back of your mind, like, you know, what's in the history of this human's life? What are maybe some things that could contribute to this? So I just, again, not 100% of the time, but there's a possibility, so you should screen for it. So these behaviors usually begin in later childhood or adolescence, again, as an attempt to distract from, reduce, or manage the emotional pain and confusion that is elicited by their history of abuse or neglect. So as we know, they offer a short-term solution to this overwhelming emotional distress by providing this sense of physical or emotional relief or escape. So as we know, one of the most like common responses when a person is asked, like, why do you cut, is it gives a place to focus my pain. It makes my pain make sense. I feel a relief when I do this. So putting all of these behaviors potentially into context. And then some other types of trauma. So there's 4 types so there's type 3. This has to do with a person's identity. Type 4 having to do with community membership. And then just understanding that complex trauma doesn't need to be catastrophic. Is anybody, so I'm going to stop my share here. This was one of the things that I was going to provide to you. And now that I'm here in front of all of you, I forgot to look this up, but how many of you are familiar with the term microaggression? So, okay, great. So almost all of you. Can somebody please define microaggression? And then can you give an example of what microaggression might be? And this can be like a group thing here.
I tend to relate it to racism and like an unintentional form of racism.
Okay.
For example, even asking someone where they're from, assuming that it's, out of the country, or telling someone with an accent that they speak English really well. It's not intended to be offensive, but it can be interpreted that way.
Sure. Thank you, Miles. Other additions to a definition, other examples?
Just that, so just to add on to what Miles was saying, like the subliminal comment or comments towards a person's either outer appearance or way of living that is separate from maybe how the person who's saying it, like separate from their lens, but they're but it often is like an isolating of the person in that comment or in that question, as Dr. Dodger says, like the other.
Yeah. Thank you, Summer. So one of the main components of that Dr. Wing talks about with microaggressions is the catch-22 that it puts an individual in. So this catch-22 of, if I respond, then I might be met with oh my gosh, I didn't mean it. Oh, it was just a joke, or you're taking this too seriously. So it's dismissive, right? Or if I don't respond, then I'm still affected by this. So it's never a lack of being affected. It's this, regardless of what I do, I'm sitting in this shit, and this person doesn't have to do anything to deal with it. So that's one of the concepts, one of the experiences that Dr. Wing talks about when you are met with a microaggression. So thank you for all of that. Okay, these microaggressions, another like kind of characteristic of microaggressions is that they break down either an individual's or a whole community's spirit in the way that they live and their like ability to kind of resist that, because it's generally not validated. You are not met with oh, thank you for sharing that with me, I will do better. It is if I call out a microaggression, I usually have to attend to the person's like anxiety or feelings about my interpretation of what they said. So generally very unpleasant experience to have. So I wanted to give all of you a definition of complex trauma from the Cordes and Ford text. So again, just so you have the definition moving forward when you are conceptualizing this and incorporating this hopefully into the work that you do. So complex trauma is a traumatic attachment that is life or self-threatening, sexually violating, or otherwise emotionally overwhelming, abandoning, or personally castigating or negating, and involves events and experiences that alter the development of the self by requiring survival to take precedence over normal psychobiological development. So it's this attachment to a figure that is inherently harmful. And in order to survive that, that's where your energy goes. It's to doing whatever by any means necessary of just getting through this experience. And that takes precedence and takes away like the focus, energy, privilege of this, of your like kind of milestone developments. And that doesn't mean necessarily like walking, talking, those kinds of things, but like learning how to nurture meaningful relationships, learning self integrity, learning self-efficacy, learning self-soothing. These are all things that aren't done just by yourself. You learn this with another person or people that are models for you. So again, highlighting, what's the importance of this course? What is the importance of this lens? So having a post-traumatic or trauma-informed lens. So I've alluded to this before, but it really helps in putting that person in context while not pathologizing. So again, I will continue to say, it's not what's wrong with you, it's what happened to you. That is a good default question of not being stigmatizing. And then, so it doesn't reduce any of the like relevance of what you see, like this clinical relevance of potentially a diagnosis, which we know is flawed, the DSM is flawed, but it allows for this person to be seen as more than their symptoms. And it allows for this person to be seen in the wholeness of their lived experience. So the symptoms that they're exhibiting now, so again, they're adaptive, they are meant to help literally sustain life. That these adaptations that have been made over time, probably without their awareness, largely without their awareness, again, to survive repeated experiences of overwhelming harm, danger, and loss. So it's just, you make sense to me, and I'm gonna hold space for you to explore this and sit in your humanity. What has happened, what I'm seeing right now makes sense because of what you have lived through. And I think that is the real humanizing piece, that validation that largely this person very well may not have experienced, particularly because of misattunement, lack of mirroring, lack of consistent care in childhood. And as we know, these experiences can happen in adulthood. This still applies. So then we're moving on to complex traumatic stress reactions and disorders, still in the Cordes and Ford text. So these three core domains of stress reactions and disorders. So we'll be talking about emotional dysregulation. So if you've experienced complex trauma or complex traumatic stress, 3 of the main domains that you'll be focusing on as a clinician working with the client is on their emotional dysregulation, their loss of self-integrity, and the disturbances in their ability to relate to and be intimate with others. So just giving you some language on what might be manifesting, what you might be seeing in the room. So some anxiety responses can be expressed as fear, terror, apprehension, hypervigilance. So just being aware of how you're received and recognizing that this is a relationship that you're building. So you may be met with apprehension, hypervigilance. You might witness panic attacks. One of the things that clients might describe to you is sleep disturbances, having nightmares. And I wanted to highlight the phobias piece. So this phobia of their own emotions. So they're so foreign, or they're so scary, or they've really never been validated. When it happens, I don't know what to do with it. So I'm just going to suppress it. I'm going to dissociate from it. So these can be of their own emotions, of other people, of enclosed spaces, of leaving home. So these can all be kind of indicators of potentially like the type of trauma that they've experienced, or this might just be a symptom of the trauma. I'm not going to leave home because the world is inherently dangerous. In the CPT training, one of the clients, I'm not fully sure. So maybe somebody who's maybe further in the training than me can help me. But remember, maybe it was the guy that experienced a school shooting that now he's like afraid to go anywhere, and it like affects his relationship with his girlfriend. But essentially what he correct me if I'm going in the wrong direction, if anyone's like, nope, that was a different client. But essentially one of the messages that he's internalized is that the world is random and it's inherently dangerous. So the only place that I can feel safe or feel like I have any control is in my own home. So that can inform like a phobia for leaving home, for example. So then there's depressive manifestations as well. So I won't necessarily go into detail on these or read them to you because you're capable of reading. So again, these are just symptoms, manifestations that you may see to understand like how these reactions to complex trauma may manifest differently. So then there's the reactions of anger and rage. So this is ranging from an ongoing sense of irritability, annoyance, disappointment, disgust, contempt, frustration with themselves and others, and also including episodes of, so this kind of baseline, ongoing, omnipresent irritability, disappointment, disgust, contempt, and then these more kind of explosive or for maybe lack of a better term, like these poignant episodes of uncontrollable rage that can precipitate impulsive acts of protest or aggression. So again, these are things that you may experience in the therapeutic relationship where you might be going along in session and then you touch on something that maybe you think is benign, and then all of a sudden you experience this rage from the client, where it indicates that there's something that has sparked that. And it may be something that the client's like not in a space to want to process or talk about. So that might be something where you bookmark, change the topic, pivot a little bit, and come back to that later. So just looking at how these reactions and these emotions can can be present in the room. So the common denominator linking all of these emotions, the group of anxiety-driven emotions, depressive, rage, and anger, is this sense of self-estrangement and emotional deadness. So this is the common link. Whatever the manifestation is, whatever the expression of this is, that the like kind of deeper down core sense of this, I don't know myself. I am unattached to my own being. How the heck am I going to make relationships with other people if I don't even feel an attachment to myself? And then this general sense of deadness that can be, reinforced by dissociation. It is an adaptation of, if I am consistently distressed, I would rather feel nothing and compromise or kind of exclude positive emotions as long as I don't have to feel these negative ones. So just knowing that that's a common denominator. So in terms of self-regulation, one of the core domains. So again, this is a different way of saying insight is important. It is not enough. So the primary challenge is not just to recognize, understand, modulate, and communicate feelings, nor even to recover from intensely distressing emotions. So this is there's something that has to happen prior to that. So that's not the primary challenge. So this is before you can even attempt to recognize, understand, modulate, communicate, you have to help the client overcome their phobia of emotions. And to connect to some of these visceral sensations that accompany the signal of them. So again, it's this self-detachment, this self-estrangement that has potentially occurred. And so I'm not going to be able to talk about it, recognize and understand it if I'm not able to even go there. So it's this process of recognizing that, not everybody is attuned to their emotions. Not everyone is comfortable with emotions. We see that with clients. I would guess with your clinical experience as well, that, we have people that are just, not comfortable with emotions. This is to another level where there's a potential phobia of even attending to, connecting to those emotions because of the trauma that it's connected to. Also, the somatoform disorder. So these are disorders that don't have like a physiological or organic cause. Like you can't see them on an X-ray. You can't see them on an MRI. There's no real physical explanation for some sort of like ailment, illness, like physical difficulty. So another thing, so if you are experiencing, or maybe, you work in a inpatient unit, or you have a network of care with clinicians, physicians, just to note that a large portion of clients with somatoform disorders have histories of childhood victimization, which are typically undocumented or unaccounted for in healthcare records. So they make even less sense because there's no record of that. But if you think about it, if this is a child who is being abused or neglected, their caregiver likely isn't going to voluntarily walk into a hospital to attend to any sort of issue. So this is just a way of being aware that there may not be documentation to like validate some of this stuff. It doesn't make it any less real for the person experiencing it. So speaking of emotional dysregulation, so the ability to identify and modulate, we've talked about this, I've touched on this already. It's an important milestone in human development. So the ability to identify and modulate, meaning like attend to, decrease distress, self-soothe, these emotional states, this is incredibly important to developing your identity, to positive self-control in relation to others. So emotional dysregulation has kind of this domino effect on many areas in a person's life. So in terms of dissociation, so again, this loss of self-integrity and self-integration, which just means, we've talked about this before, of like when you kind of integrate all pieces of your history. Remember, we talked about this about when we read about captivity, of, you know, there was this kind of like pre-trauma self. Then there's this during trauma self. And then you hopefully are working with a person post-trauma. So again, thinking of safety, is this person still experiencing trauma? Are they still unsafe? So, you know, assessing for that. But this integration, one of the difficult pieces can be, while somebody is experiencing their trauma or they're in captivity, they may do things to survive that are very counter, for example, to like their morals, their personal ethics, things like that. So there's this desire to dissociate from that or to repress that. And one of the things that we do as clinicians is to help that person integrate all pieces, all parts of their story to this fully integrated sense of self, with compassion along the way. So with dissociation, so this is happening adaptively, right? So if I am consistently not attended to, if I'm experiencing abuse, if I'm experiencing neglect, I've got to push down or distance myself, dissociate from this emotional experience to survive. So it's, again, very adaptive, but if it's done over and over, if it's recurring, this process can become automatic and involuntary. You see this sometimes when like with some diagnoses of things like a dissociative fugue, dissociative identity disorder, dissociative characteristics of PTSD, which we'll talk about in a little bit. But this can be done kind of out of the person's awareness. So it's you know, almost like a blackout, where they come back and they're like, did I miss something? That they're, even the dissociation at maybe the acutest sense of danger or of danger or harm can be met with a automatic dissociating. So just being aware that, so sometimes we talked about this a few weeks ago, when you're kind of taking a, like when you're doing an assessment with a client and they mention like some trauma that's happened. And then you ask them about it again and they go, I never said that. What are you talking about? It's not necessarily that they're like rewriting the script. They may have dissociated while they shared that with you. If they're sharing a trauma history, they may automatically dissociate when they are discussing it and then have no memory of its discussion. That can happen where they've maybe dissociated, so it's not even like readily available in their memory. So this was one thing that we talked about, of like, you know, maybe you're taking this trauma history, they share about the history, and then when you ask about it again, they genuinely don't have a memory of not only telling you, but of the actual trauma either. So they may have been in like a dissociative state that allowed for them to share it, but they don't have a memory of the sharing or of the actual trauma. So when they're saying, I never said that to you, that didn't happen, they're not necessarily lying, or they're not trying to cover anything up. It can be a genuine lack of memory of that happening. So as we know, when you have a struggle creating and maintaining a relationship with yourself, that can spread to interpersonal relationships. So exposure to complex trauma, as we defined earlier, of this traumatic attachment that is threatening, and then the need for survival and taking precedence over any sort of development, it can be, what can happen is that can create some vulnerability to sexual dysfunctions and disturbances. So if you are seeing, so again, you may see couples, and one of the presenting issues for the couple may be some sort of sexual dysfunction, whether it's kind of like physiological, biological, or it could be a disturbance in terms of safety, or, so it might manifest itself physically, and it might manifest itself psychologically. But the point of this slide and me talking about this is when you have a client who is presenting with this, that you should really take a trauma history to see if there's anything that may have contributed in their past to their current sexual or intimacy problem, the presenting problem that they are bringing to you. So complex trauma or complex PTSD and developmental trauma disorder. I've alluded to this earlier in class, but neither of these diagnoses, constructs, they're not in the DSM. For whatever reason, van der Kolk has some pretty, I think, like insightful, maybe politically charged rationale or explanation as to why developmental trauma disorder has not been put in or included in the DSM-5. Basically, like his thought is that, well, child abuse is a public health concern. However, we don't really treat it as such. And it's something that's very seemingly overwhelming and difficult to attend to. So if it's included in the DSM, that might mean that we have to put some more effort and resources into this, and people aren't ready to address this. Like larger societal bodies aren't really ready to attend to this. So complex PTSD, as it's been defined, and developmental trauma disorder neither are included in the DSM-5, but that doesn't mean that you can't conceptualize individuals with these criteria or categories in mind. So complex PTSD, I just wanted to refer you to pages 47 and 48. So again, when you're working with individuals, just because complex PTSD isn't a diagnosis option, doesn't mean that you can't still conceptualize and move forward with a individual thinking of that as potentially what's going on. So same with page 49 in the text for developmental trauma disorder. One of the things that was mentioned is that the dissociative subtype of PTSD has a similar formulation to complex PTSD. So again, for insurance purposes, for treatment purposes, if a diagnosis is necessary, that you may be able to go with that diagnosis to inform treatment or to, have insurance reimburse your time. So again, you can refer to these lists to better speak to the effects. Oh man, I did it again. The effects of the client's experience. So last but not least, increasing identity and relational functioning. So with all of this, like, what do we do with it? So primarily what we have for PTSD are cognitive behavioral therapies. So they're working on treating the cognitive or post-traumatic stress symptoms. And it is argued that we need to expand the treatment that we provide or the models that we provide to talk about interpersonal relationships, to talk about identity. So these aren't really things that are included in like a CBT approach. So knowing that many survivors who have experienced multiple complex traumas, they present with significant and highly distressing difficulties in both their identity and interpersonal relationships. So we should really include that in our models. And the models that we're learning both in the Herman text and in the Cordes and Ford text, they do attend to this. But if you go out into like the world of PTSD, you're going to see a lot of CBT focus, potentially primarily because it's a lot of clinical psychologists that are treating individuals with PTSD. It's the largest kind of like treatment population that we are informed by are combat veterans. So really what's used at the VA, for example, again, lots of clinical psychologists, lots of CBT. So as couple and family therapists, we can expand that and include issues of identity. So we can, talk about existential stuff. We can do Gestalt, integration, things like that. And then interpersonal by all of our relational training. So some of the identity problems that a person can experience are the ability to determining their own needs and entitlements. So again, if I was basically conditioned from a very young age, this is my infancy, just a package of a human. Then, so if I'm basically conditioned to attend to somebody else's needs over my own, I'm not even going to know what my own needs and entitlements are. Entitlements meaning like rights. We are entitled to things as humans. So I don't want it to, do the, like, I deserve this thing because of whatever. It's not that kind of entitlement. So also this individual can struggle with maintaining a consistent sense of self or identity in the context of strong emotions or the presence of compelling others. So this really speaks to Bowen's concept, or it's a concept of differentiation, self-differentiation. So it's the two definitions essentially of self-differentiation. So they're on an intrapersonal level and an interpersonal level. So remember, differentiation is the balance of connectedness and autonomy. So if we are fully autonomous, lack connection, that can be isolating. But if we are fully affected by others and really pulled toward like the emotional system of others, then we really don't have boundaries. So it's like one is really rigid boundaries, one is pretty diffuse boundaries. Neither are in totality. Like if it's completely rigid, completely diffuse, they're not helpful. So the sense of self-identity in the context of strong emotions, that's the intrapersonal concept of self-differentiation, where there's this balance between cognitions and emotions. They both serve an incredibly important role. If we are fully intellectual, then we are essentially dissociated or distanced from our emotions. That's not helpful. If we're fully emotional and all of our decisions are based on like an emotional reaction to something where we have no kind of logic, or we don't engage our prefrontal cortex in our decision-making, that's also not helpful. So self-differentiation in this balance of cognition, intellect, and emotion. And then the interpersonal of connectedness and autonomy. So that's really one of the a therapeutic approach concept that you can apply to an issue with identity. Also, a problem with having an internal reference point at times of stress. So if you're dissociating from the emotions or disconnecting from the emotional antecedents, so this is where some CBT can come in here and be useful. If you're not understanding the physiological sensations or any ability to soothe, you're going to have a difficult time identifying a reference point. Predicting your own reactions or behavior in various situations, because again, it may be very informed by other people's responses, or you can be so highly emotional that it's just a reflex. It's just a response that you're not really engaging in the logical or intellectual process because you haven't ever had permission to, you haven't been able to. And then being one's own best friend, that is having direct access to a positive sense of self. So, being very critical, again, believing that you are inherently flawed, bad, disgusting, terrible. If that's your narrative, you're probably not going to be, very kind to yourself or have that self-compassion. So some further issues with identity, and this is some of those origins, is when introspection occurs. So when you are a child, for example, and you're thinking about what's going on or trying to engage in this process, it's punished because an inward focus takes the attention away from the environment and therefore can increase danger. Also, the greater internal awareness means that in the context of ongoing trauma, there's greater emotional pain. So you're like, forget introspection, because it's not only that it takes attention away from the environment and can increase danger, it can take attention away from the caregiver, which can also increase danger or increase, like this negative response to you not paying attention to, connecting to, giving privilege to that person. So it's not only the environment where like things could be dangerous, people can also be dangerous. So how to intervene? Because our self-development is involved in interactions with caring others, we as clinicians can provide a really powerful, not only relationship, but environment that can foster a sense of identity. So we talked about this a couple of weeks ago of, encouraging self-exploration in all of its meaning, likes, dislikes, whether that's emotional, physical, intellectual, and just like really giving a space to explore, like, what do I want? What do I like? What do I believe? So we provide a space to allow for this self-development to happen in a caring, safe relationship. So we are working, as we've talked about, to provide safety, support, self-validity. So it's, we validate. That's one of the, kind of core skills that we learn in our field. And that is a modeling for the client to see validity in their own experiences, their own being, their own identity. And then again, I just touched on this of the encouraging of self-exploration and everything that means. So for providing safety, like I've mentioned before, this ability to be introspective, to just think freely, to explore, it's a privilege, it's a luxury that can only occur when the external environment doesn't require hypervigilance. So that's one of the reasons why we establish safety and understand, the living situation, the context of the client right when we see them. Because if we're trying to go like this kind of higher order insight, introspection, and they're still just trying to survive their environment, there's a disconnect. There's an inability of the client to engage in that process because there's basic needs like safety that's not being met. So the client should feel physically safe in our space while they're with us. And then this at least temporary safety that they're feeling in the world. Oh, and I'm sorry, I try to take away all these, he or she. So they should experience psychological safety. So we should be non-invasive, careful to honor the client's boundaries. So like consent is at the core of everything that we do with, I would argue, every client. It's especially important with clients who have experienced trauma. And then we need to be reliable. So this is a reparative relationship and a reparative experience for the client where we're communicating and following through and being consistent in demonstrating stability and security. So it is very common, and I say this to you we've talked about this before, of like not taking the reactions of your client fully personally, because it doesn't mean that you didn't do anything to spark it, or there's not this alliance rupture that should be attended to. Sometimes it has nothing to do with you. So the best way to gauge that is to give permission. So remember, as collaborative as we want to be, we still have power in that relationship. So you have to give permission to talk about these things. So if there's a reaction from the client, instead of you going, was it about me? Maybe it had nothing to do with me. Like, create space to have that dialogue and honor if the client's like, oh, no, definitely not engaging in this. Cool. But with the consistency of broaching that topic of, so tell me, like, how are we doing? Tell me a little bit about our relationship. How are you experiencing me? Are you feeling safe? Those types of things. That with that consistency, you can get more and more like honest and transparent responses from the client. Shouldn't expect it, and it might take a lot of time, but just sticking with it, consistency, predictability, that is what we're providing. So just knowing that the client's sense of relative safety can wax and wane throughout therapy. So that can be extra therapeutic, that can be in the therapeutic relationship, but this is something that you're wanting to gauge and assess, whether it's formally or informally. Let's talk, so you can define safety for them, let them know this is something I'll be checking in on, and then that can be like part of your joining process at the beginning of sessions. How are we doing in terms of safety? How are we doing with our relationship? How are things going outside of therapy that maybe we need to attend to? So supporting self-validity. So the approach that's advocated in the Cordes and Ford text, I believe maybe it's the Briere, is not to argue with the client regarding any sort of thinking errors. So this is something that can be engaged in later on, where maybe they have this narrative that's very harmful to them, and once you have established some therapeutic relationships, some safety, consistency, trust, then you can challenge some of those things. But initially, it's really important to just hold space for the client. So you're going to want to work with the client in a way that they're able to perceive any sort of inaccurate assumptions and reconsider them in light of their current relational experience. So remember, these are individuals who are, functioning kind of out of this old schema. They're in a survival mode when the survival mode may no longer be applicable. And so they're generally in therapy because the way that they have adapted to cope isn't working, and quite frankly is creating some distress in their relationships, usually. Whether that's a relationship with another person or a relationship with themselves. Remember, we are in a relationship with ourselves as well. So instead of being like, nope, let's, rethink or like replace this cognition with a more adaptive, healthy one, that it's almost like this motivational interviewing type approach where you're holding space and allowing for them to process and do some of the work on their own. It may need to be modeled, but as you're being consistent, as you're validating some of their experiences, and because you're not sitting there validating like, yeah, I can see why you would think you're a piece of shit. Like, that's not what we want to validate. We want to validate the pieces of the story and give attention to the pieces of the story that validate the humanity of the client. So if you're, by stressing to the client that their experience is the ultimate focus, and by helping the client to identify and label their internal feelings and needs, so that's what you're working with. Whenever they're discussing a need or a feeling, that's something that is probably rarely done with an individual who has experienced complex trauma, that you're really highlighting that and attending to that. So you want to help them build a coherent and positive model of themselves. And by validating and modeling that and holding space for them, that is what you're doing in that reparative process. So you're a little bit of a proxy parent. Again, this is a reparative relationship. We'll talk a little bit more about how to, manage boundaries around this. So you're providing this space to be attuned. So you're attuned to the client, you're mirroring the client, you're validating the client in a way that parents should have. So you're providing a support that should have been provided to them at a later phase in their life, so that this can be an unlearning and reparative experience for them. Okay, so I'll go ahead, stop the share here. I think that we're making pretty good time. We'll go ahead and take a break, and I will see all of you back here at 12:12. All right, so let's finish up the last few slides here. Then we'll get to some drawing, and I think we'll get out of here a little early today. Again, any questions, comments, clarification I can provide on anything that I have presented on so far, or any thoughts that were sparked while you were reading? All right, we'll keep going. All right, so I think I am recording. Okay, cool. So going back to this supporting self-validity. So, some of the topics, some of the techniques that we talk about can feel a little abstract. So here are some very tangible ways to support self-validity, self-identity. So one of the goals is to get this human sitting across from you more attuned to themselves and acknowledging the things that have happened to them and how they are affecting them and how they can heal. So you can do this through encouraging self-exploration. We've talked a lot about this. And just so you know, self-exploration can be like engaging in things like self-pleasure. So this can be things like masturbation, like figuring out what feels good, what works for that person. This very well could come like later on, but I'm just saying, like when we talk about self-exploration in all of the ways, that's one of the ways. It could feel re-traumatizing. It could feel very unsafe and, you know, something that they really don't want to engage in, but I just want to put it out there for something that could be very healing and very helpful for the individual. So how do you do self-exploration, or how do you encourage self-exploration? So this is helping the client to become more self-aware through asking their internal experience so, you know, when we talk about this, what does it bring up for you? How is it like for you sitting right now in this room with me? So using that immediacy, this can look like multiple gentle inquiries about the client's early perceptions and experiences. So it's not a tell me all the details. It's just like dipping your toe in, bringing it back out. So that kind of exposure and their feelings and reactions during and after their victimization experience, their abuse or neglect, their trauma experience. And what are their thoughts and conclusions regarding the ongoing process of treatment? So just in every aspect, engaging in conversation for them to acknowledge, become more in touch with, and articulate their own internal experience. So recognizing that this person, so again, talking about complex PTSD experiences in childhood, when they're external directedness, they have this external directedness, right? I need to make sure that I attend to and do whatever I need to for other people or for my environment to survive this. This works against an individual's ability to self-understand, their ability to create an identity. So allowing space for them to talk about, like, what do you like? What don't you like? Tell me about your view of yourself, your view of other people. What do you have rights to? What are your obligations? So these are all potentially conversations or questions that the individual has never been asked before or never taken time to think about, has never been given space to just talk about this and explore this. So our role in this is being supportive, being engaged, so attuned, mirroring, supportive, being this helpful attachment figure. So your primary interest is more than just symptom reduction, that you want to help this person identify and develop their own internal sense of self and their ability for self-determinism. So remember, thinking about an individual who you may look at them and their general demeanor is resignation. I have no agency. I have no ability to affect anything. And this is a message that I've been given and was reinforced since infancy. So that sending the message that they have agency, that they have the ability to create something for themselves is important. So we've talked a little bit about this, the relational disturbance. So if you believe that you're unlikable or unattractive and that others aren't to be trusted, you as a therapist are no exception to this. So this, of course, affects the ability to create connections and attachments to other people. So this, I think this is where the example of the person that where the therapist was being, kind and patient and validating, where, in that first session, the therapist from their perspective thought, oh, that went pretty well. And then the person came back the next session and was very upset. They were disgusted by the way in which the therapist talked with them, attended to them, which was informed by this schema of being unlikable, unlovable, invaluable, or not valuable, not invaluable, not valuable. So just kind of being ready for any sort of reaction to come back to you. And being willing to explore it, but also being willing to back away from it when the client's like, nah, I'm not going to engage. So remember, it's all about buy-in. It's all about consent. It's all about going at the client's pace. All right. So there's the concept of exposure. We've talked a little bit about this. So this is where, a lot of the CBT oriented or CBT informed approach comes in here. So when you are in therapy and you're talking about triggers, memories, your own relationship, your own therapeutic relationship with the client can be an inherent trigger. Also, the way that you present could be triggering. For example, if you have a client who has experienced abuse at the hands of a man, as a male presenting therapist, that could be inherently triggering. So just being aware that, one, you may not be the best fit by virtue of just like who you are, or quite frankly, kind of like what you look like or what you might represent. And being like aware of that and acknowledging that. Again, it could be things like age, race, sex, the power differential, which is really difficult, like regardless of the therapist that's going to be there, but there may be characteristics of the therapist that can be safer. So again, it's remembering that you're inherently not going to be the best fit for all of your clients. This is regardless of trauma status. But at the end of the day, recognizing that if this is something that's a characteristic of you that you might be maybe like hoping that the client can work with, or maybe potentially even imposing on the client that they work with you. I recognize that sometimes resources can be limited and you may be one of the only options, but at the end of the day, it's our job to provide the best care for our clients, even if that's not with us. So just recognizing that by virtue of what you represent, how you look, that could be a trigger for your client. So another thing to remember is that even positive feelings that are associated with a therapeutic relationship can trigger distress. So if the client has, these feelings of adoration or even love, and that's okay. So just a personal kind of approach is like that unconditional positive regard. I conceptualize that as love. And so I can say that I have love for all of my clients. And I don't think that that's like a boundary violation or anything, that would be an ethical concern or anything like that. But that's kind of how I approach my clients, is I have this unconditional positive regard for them that I think can be akin to love. So, we could get into a whole conversation about transference and countertransference. I also have some thoughts on those and some of the antiquated pieces of that, but I digress. So these loving feelings that the client can have towards you, or the perception of these feelings that the clinician may have for the client. So my stance of this unconditional positive regard for my clients can be triggering. for some of them. So it can activate potentially sexual feelings and fears. I think these are things that, like, particularly like the sexual attraction, that I would argue is inevitable in terms of the therapeutic relationship, because again, you're providing, again, unconditional positive regard, validation, compassion, attunement, support, like these things that feel so good for a client to be on the receiving end of. Can that sometimes inform or contribute to sexual feelings? Absolutely. Is that something to like run away from and refer out? I argue not. Perhaps that is something that you will talk about in your sex therapy course, but I don't believe that that is an automatic refer out. I think that's something that can be therapeutically worked through. So this, moving on, the perception of the therapist caring or this acceptance can trigger fears of losing that experience. So sometimes what can happen is the client can, quote, stay symptomatic, stay sick, because they're very afraid of losing this relationship with you, knowing that you serve a purpose. Like, our relationship is inherently boundaried, is inherently based within parameters. So being willing to talk through that. So again, this could be akin to abandonment from an attachment figure. So we want to, as we're treating the relational traumas, we want to ensure that the reminiscent aspects of the therapeutic environment are not overwhelming. So again, this whatever may be triggering in terms of exposure, because it's not just necessarily, the content of what we're talking about, it can be the environment. So just being aware that there are a lot of things that could be triggering and not being afraid to broach those topics. Yeah, so there are a lot of things that you're in control of in that space that you can temper, that you can modulate to help the client not feel overstimulated. And that will be guided by conversation with a client. And I think this is our, oh, no, not yet. Ooh. Okay, so activation is, so these are the emotional responses to early relational memories that can be responded to in the room by like kind of dramatic or potentially disproportionate responses that can seem kind of random or illogical, but ultimately they are quite logical. So again, it's this, they represent a conditioned cognitive emotional response to triggers. So just attending to that activation where you're not like taken aback to the point where you become distressed and the client has to attend to you. So you're always this model of calm, you're this model of consistency, recognizing that some of the things that you discuss can be activating for the client. So again, it's like these activations can seem dramatic, they can appear irrational, contextually inappropriate. So again, if you're looking not from a trauma-informed lens, you can go, oh, this is pathological. This is problematic. If you're looking at it from a trauma-informed lens, it's all right, this makes sense. Let's back up. Let's figure out what happened. And then let's either process this or like wait a little later, going at the speed of the client to process this later. So the concept of disparity is creating a disparity between what you provide in the therapeutic relationship, in the therapeutic space, and what the client has experienced in terms of trauma, abuse, neglect. So when you're working with chronic relational trauma survivors, children, adults, you can behave, what the goal is that you're going to behave in a reliably safe and non-exploitative way. So this will take time. So this consistency is incredibly important. And so that's where the client can see and experience you and your environment, your space as safe. So you're creating a disparity between how they potentially see the world, how they see relationships, how they see people, and the experience that they have with you. So you are a model to essentially be like a microcosm of a larger shifting of a schema. So you can, again, it sounds like there's a lot of weight to it, because I think when you're creating a reparative experience for somebody who inherently sees the world as dangerous and harmful and exploitative and violating, that for you to provide a 180-degree different experience, that has a lot of weight. So I don't say that to be like, I don't say that for it to be overwhelming and scary, but if it feels overwhelming and scary, I also think that's appropriate, because what we do is important. What we do isn't the only thing, right? So you're creating a network of care, you're involving other people in this as well, but you can be really pivotal in the healing of another person. Again, it's not solely yours to bear, because that's where we'll talk about some of the boundary issues that can be created in future classes. But I will say what we do is important and can be very healing and reparative. So if you don't accurately assess the hypervigilant or fearful client, if you're not gauging for safety, if you are not gauging for their experience of your relationship, if you're not assessing that, then if you are providing exposure, so you're talking about and processing the trauma, or you haven't asked them about potentially anything in the environment that might be triggering, this exposure could be incredibly overwhelming. So again, you don't want to do this until this disparity, meaning the experience that you're providing them as a human, as a professional in your space, is different from what they have come to believe about the world. So then there's the idea of counter conditioning, which is achieved through things like exposure. So the goal is to work within the therapeutic window. So understanding when is the client feeling safe, kind of primed for some action, they have buy-in, they've consented, things in their extra therapeutic life are safe, things with you are safe. That you've provided sufficient relational contact, they have support, you have expressed and demonstrated consistent positive regard for them. That's where you can have this distress diminishing and nurturative relationship, and you can put them in this, they can be in this state while they're working with you. So this is where some self of the therapist stuff, some self-awareness of you and how you are responding to being affected by, because we are not unaffected in this relationship. We're going to have a whole class covering kind of vicarious trauma and how this affects us. This is super difficult stuff that we're hearing, and we're not robots. So if your desire to save, to fix, to provide for your client is really activated, this can, and we've talked about this before, this can inadvertently reinforce dependency needs. So again, if you have a client, for example, with an anxious attachment, you could be reinforcing that attachment inadvertently by being very available, by, easing tension immediately, by wanting to take away distress and stuff like that. And this is attended to through supervision, through consultation, through your willingness to check yourself, to challenge yourself. So this tendency is not abnormal. If this is a feeling that you have, all I ask of you is to be willing to discuss it, because it has to change, but you can't change it by not talking about it and not brainstorming. So hopefully you feel like you're in a supportive environment, you have a supportive supervisor, you have maybe a consultation group or colleagues that you are working with, that you can be honest about your experiences with this. So again, this may be where you're having a vicarious healing experience, which again, it's not a bad thing. When you lean into it and it serves a really significant purpose for you, that might be where you're towing a line in terms of boundaries and potentially ethics. So continually examining your own needs to protect or rescue your client. So again, it might provide you with something. This may be a story that you deeply resonate with and you want to have, you are, committed to creating a different experience for your client. And when that becomes maybe all encompassing or a focus of yours, that might be where you want to talk about it, because you might be, you might be invested beyond a professional level. All right. So on that note, we'll go ahead and end that. Again, questions, comments, even thoughts on maybe that last slide in terms of, this desire to save, rescue, maybe even a fear of a tendency of that.
I've definitely experienced that a lot with my clients, especially like younger clients. It's funny because I had a supervision with Dr. Espinosa last week. And she had pointed out that because it was a family session, but the 7-year-old daughter started she was like shutting down. She was like crying, and I noticed myself like wanting to save her, wanting to like make her feel better, like not, feeling that way. And so I was kind of hounding her with questions, and even like kind of hounding her, I think, with like some sort of psychoeducation on, oh, well, how can we cope with this kind of a thing. And it was funny because Dr. Espinosa was like, stop. Like, she's shutting down, like, what are you feeling and stuff. And I just, I felt like I had to save her. And I think like subconsciously I was doing that because I kind of saw some of myself in her, like as a young girl.
Absolutely.
Like I saw, because I, still do, but like suppress a lot of my emotion or a lot of that pain. And she was doing the same thing because she was in a domestic violence situation with her parents. So I don't think she's been validated a lot in her emotions, but it was like, oh my gosh, yes, like I see myself in her, and I'm trying to make her feel better because I don't want her to be like me.
Yeah.
Or I don't want her to feel what I felt, kind of thing. So yeah, no, I wasn't thinking about it initially. I was just like, oh, it's just because she's a child and I don't want children to feel, sad or upset.
Sure.
But I think it was much deeper than that.
Yeah. Well, thank you so much for sharing, Jada. And I think you bring up two really important points here. So I'm going to highlight what you just said of like, I don't want kids to feel like bad or upset. So, that's an important emotion for kids to feel too, right? Like, so when it's kind of like that, potentially that toxic positivity of like good vibes only, that kind of stuff where we think we're providing something helpful, but really it's invalidating of true emotions. So what I'm going to learn is if you tell me, don't cry, don't be upset, it's not going to stop me from feeling sad or upset. I'm just learning to not show you. So super important. Thank you so much for bringing that up. The other thing that I want to highlight in what you shared, Jada, is something to be very aware of when you're working with clients is, so my guess is, I'm making a guess about your experience, Jada, so please edit me or correct me if I'm inaccurate here, is potentially the child's distress created some anxiety in you, right? Like you were feeling some level of discomfort. So you're like, shit, I'm going to inadvertently attend to my own anxiety, attend to my own distress. So I'm feeling distressed by your emotions right here, or your reactions, responses. So I'm going to attend here to quell this. So then I can quell this. And that's what we do a lot as humans, is we attend to others based on our own anxiety, and being in the therapeutic role doesn't make us immune to that. So if that was accurate, thank you for allowing me to kind of articulate that. And also thank you so much for sharing that, because it's so common that we're like, oh, I was just providing something. So I always do that with my supervisees too, with how are you feeling in this moment? Okay, so did that help your anxiety? That's not the goal. So thank you so much for being vulnerable and transparent in that, and providing a really beautiful example of some of the ways that, we very much take up space in that therapeutic experience. Okay, let's do some drawing. So if you have crayons, colored pencils, whatever, near you, go ahead and grab those. We have about a 15-minute exercise. So my hope is that you're seeing some utility in this and potentially using some of this with your own clients. So this is a mindfulness. I don't know if you can see me, but I'm doing quotes here of art therapy, because it's with an art teacher. This person isn't an art therapist, and forgive my 50 million tabs being open. Okay. So we might have to go through a advertisement here. And maybe if we feel comfortable at the end of this, we can share what we've created, but please, no pressure.
Hi guys, my name is Megan. I'm an art therapist with Project Create, and I'm here to do some mindful drawing with you today. Obviously, all of our situations are a little bit different right now with quarantine, not going to school, not doing activities in the community that we normally do. And all that can sometimes be a little bit stressful. Change of routine can be uncomfortable. So sometimes doing art making can be helpful to help us de-stress and help us relax and be present and enjoy some of the time we're spending home. There's no right or wrong way to draw, so I'm just going to show you some different ways to get your creativity going and get started. One way to get started is just by drawing as you breathe. So sometimes I like to focus on drawing my inhale and my exhale. Inhale.
I also want to note that you do not have to draw what they're drawing. Like, you can, whatever comes to you for inhale and exhale, create whatever feels right for you.
Exhale. And seeing where that line takes you across the page. You don't have to keep doing that, or you could if that's working for you. But the idea is to be present in the moment and focused on what you're doing and not worrying too much about anything else. If you're still breathing and drawing your breath, that's great. If not, sometimes it can be nice to play with some of those shapes that you've created already with those lines and seeing where those bring you. Again, there is no right or wrong way to do this. Maybe the shapes start to look like something else. Maybe they start to take a life of their own. Maybe we find plants or animals or faces. Maybe we don't. Found a pumpkin down here. Wherever your breathing takes you, wherever your pen takes you is perfect, and that's exactly where you're supposed to be. Sometimes filling in some of these other spaces with colors or different line patterns can work really well. If there's two of you, sometimes I like to do this exercise by drawing a little bit myself and then giving a partner a turn to draw. Make it into kind of a game. Again, maybe we find some faces in here. Some different characters. Maybe those characters become part of a story. Maybe they work their way into some of your other drawings. Maybe they're people that you already know. Or characters that you've seen on TV or in movies. So this was just one way of getting us started, and I think that where we've started to go with this is definitely really exciting. So I want to show you guys some other ways to get started with your drawing so that you have some other ideas if this one didn't sit with you. Another fun way to get started can be with shapes or forms that you already know of. So circles or squares that you see in your environment, or letters, numbers. Sometimes I like to get started with my initials and see where that goes. So if you want to spell out your first or last name, or do your first, middle, and last name, something like that could work really well. So that's what I'm going to do here. Keep these letter forms pretty expressive and not so tight. And then I'm going to see where they take me. Definitely go through a lot of pens when I'm drawing. So I started to see different shapes right away in this one, but sometimes when I use my initials, I like to think of things that are more unique to me since that's part of my name. So if there's a sport or a team that you really like, a favorite singer or group, it can be fun to kind of connect those things to your initials and to the drawing, things that feel like they're a part of your identity. It can help you feel connected to those things while you might not be engaged with them right now. Sometimes we find these shapes that keep coming back in our artwork. I've been making these stars forever. What are things that you guys enjoy drawing or you find yourself drawing a lot? Those can always be really great places to start when you want to make something. And it's interesting how they change and grow with us. Sometimes when I get a little too fixated on one part of the drawing, it's nice to completely change your perspective. Again, sometimes we might find shapes that look like something, and sometimes they might just be patterns that feel really nice to draw. Sometimes patterns and repetition, like I was doing over here, can be really relaxing and they can really help ground us. Triangles are another one I find myself going back to a lot. So, this is another way to get started. If this is something that makes sense for you and something that you got really excited about, go for it. If you want to keep the letters a little bit less abstract so you can tell where your name is, it's another way to approach it. I went for some pretty big, crazy lines, so whatever makes sense for you. So for this last one, I'm going to get started by closing my eyes and just doing a completely random scribble. And seeing what I can find in here. Sometimes it can help to turn the page around. Again, if you have somebody else with you, it can be fun maybe for them to draw the scribble and then you to try to see what you can find and then switching it up. And I have an elephant. And again, for these tutorials, I've just been using black pens, but you know, if you have other stuff with you, it can be great to go in and add any other kinds of colors or a different art media that you might have. There's no rules. So my elephant is gonna be standing in a green room. Seeing what you can find in a scribble, sometimes you have no idea where that one line can take you. Just like with any of those other ways of starting drawings, you never know where your name or your initials are going to take you, or where just your breathing can take you. And no matter where you are, you can get out of your own head and into that creative place. It's important to remember that whatever you're working on today doesn't have to be a masterpiece. It doesn't have to be framed and hanging in a museum. It's just about having fun, being creative.
I'm going to go ahead and pause this, y'all. If you have created something that you want to continue to work on, great. But I just want to leave enough time for all of us. If anybody would care to share, you don't have to, but if anyone wants to show what they've created, I would love to see it. No pressure. Danny, are you showing? Oh, that's cool. Thank you so much for sharing that, Danny. So yeah, this is something hopefully, you know, the led by breathing, kind of this very undirected free flow is something that can be helpful, not only for you, but something you could potentially show clients. So again, this is a like attunement with yourself, a self potentially like emotional regulation thing, a mindfulness. So I'll continue to provide for you different ways of utilizing and practicing mindfulness. So I am interested, since we have a couple of minutes, sorry, I guess we're not going to get out early, of any thoughts so far on the mindfulness that we have done. So we've done progressive relaxation, we've done imagery, so guided imagery, we've done some guided-ish breathing, and now we've done some art, mindfulness art. Does anybody have any thoughts on or a favorite, or one that they really didn't resonate with or anything?
I just realized how much I miss working with colors, just studying with colors, just there was something about it, just feeling out colors.
Cool. Tapped into some of your creative brain. Thank you, Danny.
I liked this exercise because I've always wanted to do art, and I think I'm too much of a perfectionist because I've never learned how to draw. So sure. I tend to go a little bit more abstract, and this kind of let me do that.
Yeah.
I've been a math teacher for a really long time, so I tend to have a lot of geometric shapes in my pictures. And also, I forget which one it was. I think it was one of the first ones we did. I forget what it was called, but we were I think it was guided imagery where we were kind of walking on a trail or something like that. And even as you were reminding us of that exercise, I can still picture that place that I created in my
Oh,
mind.
cool.
Like it wasn't a place that I had been before, but I still like have this mental image of where I was and what it looked like, which
That's
kind of cool. So I guess it did stand out to me.
Yeah, wonderful. Thank you so much for bringing that up 2 miles, because one of the beautiful things about guided imagery is the reminding like your clients or anybody that you're doing it with that you can always go back there. So you created this place you've never been to that potentially created a sense of safety, warmth, comfort, that your brain created for you, so you can go back there whenever you need to. All right. Well, thank you everybody so much. I think I'm gonna do like a derivative of what we did today next week, where you're given again different approaches. So again, if you like Danny, if you like colors, feel free to pick up some crayons or something if you don't have them, but we're gonna let our creative juices flow again next week. So thank you so much, everybody. And I will see you next Tuesday.
Thank you, Dr. Lappin.
Dr. Lappin.